Hello, I'm Dr. Jayne Morgan. I am a cardiologist and women's health expert and serve as the Vice President of Medical Affairs for Hello Heart. I'm here to really talk with you about women's health and women's health from a heart perspective, a cardiac perspective. Part of the challenge, or even part of the problem, if I am to be honest, with healthcare for women is that it has been considered only with regard to our reproduction. So it's all about breast and pelvis, sort of what we call bikini health. But we never get EKGs. No one ever talks with us about our heart. And actually, it's heart disease that's the number one killer of women. Now, that may come as a surprise to you. In survey after survey after survey, that number really never tops more than 50% of Americans recognizing heart disease as the number one killer of women. What do you think most women say is the number one killer of women? That would be breast cancer. And that is because breast cancer is very serious, of course, but it is not the number one killer of women. Not only is it not number one, it's not number two or three, it's number seven. In fact, when you combine all cancers together and add them all up, heart disease is still the number one killer of women. When we go back, all the way back during our COVID pandemic, at the height of the COVID pandemic, with our most virulent variants, Delta, and we had more than 1 million Americans die, and we saw COVID come up the list of reasons for death from 10 to 8 to 7 to 5 to 2. It never reached number one because even at the height of COVID, it never toppled heart disease, heart attacks from the number one spot of killing not only Americans, but killing women. And so I'm here to talk with you about heart disease because women in particular have two particular times in our lives where we have vulnerable periods of our lives where we actually have an accelerated risk of heart disease, and that's during pregnancy and also during perimenopause and menopause. And I'm going to talk with you about that. But before we start, let's level set with regard to symptoms of heart disease. So, part of our challenge is that the symptoms of a heart attack in a woman may not be the same as the symptoms of a heart attack of a man. And that may be a surprise to you. What do we know about heart attacks? People grab their chest, you have chest pain, chest pressure, shortness of breath, maybe you pass out, maybe you get dizzy. But guess what? Women may not have those symptoms. We may actually have a little fatigue. Who doesn't feel tired? Or have some back pain, a myriad of reasons why you may have back pain, or maybe even nausea or stomach upset, or maybe you just feel run down, sort of like you have the flu and you just can't shake it. Or maybe even you have jaw pain that could send you to the dentist for an oral exam. Or you might have pain in your right arm and not your left arm. That's part of the reason why heart disease is not only the number one killer of women, but the first heart attack of a woman is more likely to be fatal than the first heart attack of a man. Because why? Because we delay in seeking care. We minimize those symptoms. We attribute them to other things, and that's not really our fault. They certainly could be attributed to other things, but it's also not our fault because we're not taught that these are symptoms that could herald the onset of a heart attack in women. And just if you think that you're not the only ones that have been taught them, physicians haven't been taught them as well. In fact, during my training as a cardiology fellow, we refer to these symptoms as atypical. Think about that word, atypical. A 44-year-old female presents to the emergency room with atypical chest pain. Atypical is a word that drives action or inaction. It means maybe it is, maybe it isn't. We're more likely to be moved into the category of having a panic attack, of being overworked. as opposed to actually having a serious heart attack. That word atypical is the way physicians actually communicate with each other. And that communication is a subtle communication, a wink and a nod, if you will, to whether it is serious or not. A man's symptoms of a heart attack are rarely referred to as atypical. And so not only has the woman herself delayed care, seeking care, because she is at home and she's busy with her children and maybe has aging parents and a busy career and a husband and a house and all of these things that we are managing. And so we delay seeking care as we minimize our symptoms. Once we reach the medical establishment, there may be even a further delay in recognizing your symptoms because they are deemed atypical. And let's talk about that atypical for a moment. Women comprise more than 51% of the population here in the United States. We are the majority of the population. So, how did our symptoms become atypical? We actually have the main symptoms. So that just goes to show you about the gender divide and what really drives how we understand and practice medicine. And so the average delay for a woman seeking health care for a heart attack is 37 minutes. That is an astronomical amount of time when we're talking about opportunities to intervene and prevent death and also prevent further damage to that heart. Every minute delay that we have from getting any patient, including a woman, from the door to the cath lab, where we can open up that artery and get blood flowing back to your heart and thereby oxygen back to your heart, decreases your chances of survival. And if you do survive, decreases your chances of surviving and returning back to your normal life without a disability, without an incredible change in the quality of your life. And that impacts women more than men because our symptoms are minimized. They're minimized by the system, they're minimized by ourselves. We also are not taught them. There is a low recognition of those symptoms by both ourselves and the medical establishment. And if we are not armed with this information, then it's difficult for us to even advocate for ourselves when we get to the hospital. And part of that advocacy is cultural. We really are taught not to challenge authority. We maybe give deference to men. Many of the physicians that you would meet would be men. And so then it is harder and harder for us to speak up. And then on top of that, you're not feeling well, which also makes it harder to advocate for yourself. So remember, the symptoms of a heart attack of a woman may be different from those of a man, and you need to be able to speak up. One little trick that I will give you: if you're having difficulty advocating for yourself, here's how you speak the language of the system. You don't have to say, "Hey, doctor, I think I'm having a heart attack," or "Could you please check that I'm having a heart attack?" Or "I heard this seminar from Dr. Jayne Morgan, and she said that my symptoms of nausea and back pain and fatigue actually might mean a heart attack." And here you are feeling poorly and you're trying to advocate for yourself. Here's how you speak the language of the system. If you think that you are being dismissed or overlooked, you ask the physician or the nurse before you leave that emergency room to please get an EKG. That's full stop. That cannot be refused. It's also reimbursed by insurance. It also has just given an indicator to the staff that maybe they should be thinking about something else. And then those results of the EKG may just redirect them from dismissing you from the emergency room and back home, where you're going to get sicker, and actually moving you into the system and into the cath lab for the care that you need. So remember, just simply ask for an EKG if you think you're being dismissed and that your symptoms are being overlooked. And speaking of EKGs, and speaking of bikini medicine, which is what I call health care that we deliver to women. It's all about the breast, the vagina, and the pelvis, as if we have no other organs, as if we don't have a heart, a lung, a liver, kidneys. We have nothing. It's just bikini medicines, right? We get breast exams, pap smears. As we get older, we get mammograms, and out the door we go. We have no other organs. Guess what men get? They get an EKG as part of their physical exam. It is acknowledged that they have a heart. So the next time you are in for your physical exam, even if you are feeling well, you're just there for a well checkup, ask for an EKG. Not because you're sick, not because I, Dr. Morgan, thinks you're sick, but because you need to have an EKG on your record. This means that if you were to get sick later in life, there is a record via which we can go back and compare EKGs to determine if there's been any change and what interval that change has occurred in. That's the kind of health care that men get. For women, oftentimes, when we're having symptoms of heart disease that may be vague, we don't even have an EKG via which to compare. So there's no interval via which doctors can even determine when this has occurred, if in fact you are diagnosed with a heart attack. When did that occur? When was the last time you had a normal EKG? So you ask for that EKG. You should have an EKG on your record, the same as men, because we have hearts. Now, let's talk a bit about different life stages of women and when we may be at increased risk of heart disease and why we don't know that, why we don't have this information, why medicine is not practiced this way. So when we talk about pregnancy, right, a beautiful time in a woman's life and life is developing inside of us, if you develop any complications during that pregnancy, so for instance, you develop high blood pressure during your pregnancy, it might be called hypertension, or you develop something called preeclampsia, which is hypertension, but now you may have a little bit of damage to your kidneys or your liver, or even eclampsia, which is an even more severe form where you may be developing seizures because of this high blood pressure, or an older term called toxemia, or even diabetes, which could be called gestational diabetes, or if you've ever delivered a baby that is a low birth weight baby, if you've ever been told that your baby has a low birth weight, all of those things are indicators and markers of future heart disease in you, in the woman. Here's why. When you are developing, if you develop any of these complications, and about 13% of pregnancies develop these complications, you may have a high-risk OBGYN added to your team who's going to manage you during that pregnancy, a high-risk pregnancy. And that physician is managing you and the baby. But not from the perspective of heart disease. And we now know that any of those diagnoses during pregnancy are actually long-term markers of future heart disease. In fact, any woman who's had these complications, your risk of heart disease increases by 2 to 3-fold. It doesn't mean that the pregnancy causes the heart disease. It's more that the pregnancy declares it. In other words, these diagnoses we now know are markers or biomarkers of future heart disease. So what should be happening is that a cardiologist should be integrated into your high-risk OB team. A cardiologist should also be a part of your team and following you. And very, very, very few medical centers here in the United States really have an integrated cardio OB team, cardiology and obstetrics. And I'll just tell you, during the entire time of my cardiology fellowship, I spent 3 years just focused on cardiology after 3 years of internal medicine, after medical school, and never once did I rotate with the OBGYN team. They were always in a separate area of the hospital, labor and delivery. But we now know that cardiologists actually need to be integrated into these obstetrical teams, especially for high-risk pregnancies. And here's why. And here's why diversity of thought and diversity of perspective and diversity of training is incredibly important. An obstetrician looks at this patient. She or he has come to assess this patient who now has developed this high risk pregnancy, preeclampsia or eclampsia or hypertension or diabetes. And she or he may say, I have a 37-year-old female in her 26th week of pregnancy who has now developed preeclampsia or hypertension. A cardiologist comes and looks at that same patient. And from my training, what do I see? I see a 36-year-old female who is volume overloaded, who has just failed her stress test. So the pregnancy, from a cardiology perspective, is not considered a pregnancy, it's considered a state of volume overload. Increased volume in your body. And because you develop these diagnoses that can be very serious, we know that you haven't been able to manage that volume overload. And that volume overload is a stress test. It's the woman's first stress test, your stress test on your heart. And if you develop any of those diagnoses because you are volume overloaded, then you have failed your stress test. And like any person who fails a cardiac stress test, you are referred on to higher levels of cardiac care, testing, preventive management, and diagnostics. That does not happen to women in the United States with these pregnancy complications. You deliver your baby and off you go. And then we challenge the maternal mortality rate. Did you know that the majority of deaths in maternal mortality are cardiac deaths? Did you know that the majority of them occur within the first year of the baby being born? It's not necessarily during the pregnancy, it's the year after the pregnancy. What we're talking about, this postpartum period. That's why we're pushing now increasingly for women, especially those who've had any of those complications, to have multiple follow-ups after their pregnancy, including with a cardiologist, because we now know that your risk of heart disease is 2 to 3-fold higher than women who have not experienced those complications. And the majority of these complications of hypertension in pregnancy, preeclampsia, gestational diabetes, eclampsia occur in Black women. Not all, but most. And it's not just Black women, it's Black women who are born here in the United States, Black women who are native to this country. Very interestingly, Black women who immigrate here and have their babies here do not have those same levels of complications of preeclampsia, hypertension, and eclampsia. It is very specific to African American women, not African heritage women coming from any other countries. If you are born here, this is very specific to American soil. And we have to think about what that means with all of the weathering, which I speak about often. So sort of the high effort coping and stress and living in a society that is very gender and race conscious, and the Black female is that double bias, the constancy of that navigation, what that means even in career trajectory, able to move your career forward, able to move into better neighborhoods, provide better schools or not, and the stress of that constant navigation, epigenetics. This is part of what we see that probably drives a lot of these complications of pregnancy, because we do not see it in any other African populations, African Caribbean, African Brazil. There are no other populations. It's very specific to African American populations. So if you have developed any of these complications in your pregnancy, you need to demand that a cardiologist be added to your team. If you've already had your baby and you're listening to me and you're having an aha moment, say, wait a second, I had that complication. Talk with your primary care physician and get a referral to a cardiologist, because we want to make certain that you have maximal preventive care. That means treating your blood pressure to goal, 120 over 80 or less, not 125, not 126. It needs to be 120 over 80. We want your cholesterol, your LDL, especially that bad cholesterol, down very low. We want you tested specifically for a genetic type of cholesterol called LP little a. This is also a marker of advancing heart disease. So you move into a different bucket to make certain that you have great care. And that's what I want for you, especially since African American women tend to have more of these complications. And then our death rates from heart disease are higher, and our death rates regarding maternal mortality are also higher. So make certain that you ask for a cardiologist to join your team. If you've already had your baby and you're listening to me and you say, oh, I had those complications, make certain that you now make an appointment with the cardiologist and give that obstetrics history. And the final thing that I'm going to say about pregnancy is for the rest of your life, you need to give your obstetrics history to every single doctor you meet. Emergency room, primary care, cardiologist. Your obstetrics history is important because it is an indicator to the physician that they need to have a higher level of awareness of heart disease for you because you've had these pregnancy complications. So even if you're in your 50s and 60s, I want you to always give your obstetrics history whenever you are interacting with the medical establishment, even if we're not asking for it. You give that anyway, because even medicine is on the cusp of trying to understand how we are integrating cardiologists with the obstetrics team. Another phase of our life, another beautiful phase. Women develop in, so many transitions, and that is menopause. And so let me give you a definition of menopause. Menopause means that you have gone 12 consecutive months without having a menstrual period. If during those 12 months you have a menstrual period at month 3, then you start all over and you count for 12 months. So even if your periods are irregular, that doesn't count as menopause. You have to go 12 consecutive months with no bleeding whatsoever, and then you are officially in menopause. So why am I talking about that? Because all of the years leading up to menopause, we call that perimenopause, and that could start as early as 35 years of age. Why is that important? That is important because the period of perimenopause is also a period where women have an increased risk of heart disease. Why is that? That is because perimenopause heralds the onset of decreasing estrogen levels in our bodies. It doesn't mean that they just drop suddenly one day, but they're starting to fluctuate and change. That's why you can get the symptoms. The most well-known are hot flashes, night sweats. That's because your estrogen levels are fluctuating. They're no longer steady as they're starting to decrease. So it's not sort of just a sudden drop off. The other thing to think about is that perimenopause has any number of symptoms. It's not just all about hot flashes and night sweats and maybe sleeplessness. There are 35 symptoms of perimenopause. And the reason it's important to know that is that these symptoms are not nothing. Even if they are not bothering you, they are indicators that your risk of heart disease is increasing. Why is that? Because estrogen protects the heart. It is an anti-inflammatory agent, and inflammation is one of the causes of the acceleration of atherosclerosis, so plaques in the arteries, but it also has a direct cardioprotectant effect on the heart. That's one of the reasons why before menopause, a woman's risk of a heart attack is less than half that of a man's. And then after menopause, it equals that of a man. Here's one area where we really aren't striving for equality with the male gender. We liked being unequal and having this advantage. But as we lose our estrogen, we slide further and further towards that higher and higher and higher risk of heart disease. Now, think about you're one of those women who also had a pregnancy complication, and you already now are going into perimenopause with that 2 to 3 fold higher risk of heart disease. And now you're starting to lose your estrogen and further driving your increased risk of heart disease. That's why this period of time is very important. And it can start as early as 35 years of age. And it doesn't mean that you can't get pregnant. You're not ovulating. Here's the fun part. You could be in perimenopause and be fertile. Your estrogen levels haven't disappeared. They've just started to fluctuate. So your ovulations may not be as regular, or it just may be starting to wane and you really aren't feeling any symptoms. Why are the symptoms important? I mentioned there are more than 35 symptoms of perimenopause. Why is that important? Because these symptoms are markers of heart disease. And we talk about night sweats and hot flashes, and people turn fans on women and everybody laughs, and women are ripping off their jackets and fanning themselves. But this is not ha ha ha. That woman is telling you, I am at an increased risk of heart disease. She is literally screaming out for help. So perimenopausal symptoms should be an indicator to you and to the medical establishment that we need to step up our preventive cardiac treatments. So what are some of the symptoms of perimenopause that you may not know about? What about itchy ears? Everything itchy ears were a symptom of perimenopause? Well, they are. And that's because as the estrogen levels drop, our skin begins to thin. And the first area we may notice that thinning skin is inside the ear. And you may start, itching and scratching that ear. What about vertigo? You start to feel dizzy, or you could even get palpitations, or a frozen shoulder that may send you to an orthopedist or a physical therapy session. You can also start to have painful sex or urinary incontinence. There's a number of symptoms of perimenopause that not only are they uncomfortable, including sleeplessness, and there is no reason to suffer. You should make certain that you get therapy and treatment. You do not need to suffer through these. But most importantly, not that suffering is not important. It is important. But I've heard some women say, I have these symptoms, but they kind of don't really bother me. I mean, it's an itchy ear. It's a little bit of a frozen shoulder. Overall, it doesn't really bother me. I'm not going to see a doctor for it. Here's why I push back on that. That is because it's not about your frozen shoulder. It's not about your itchy ears. It's not about the vertigo. It's about the symptoms telling you something. What are they telling you? They are saying, hey, your risk of heart disease is increasing. Why don't you check in with your doctor? And when you see your doctor, what are some of the things that you should check for? People always say, oh, I'm in perimenopause. I'm going to go to my doctor and check my hormone levels. That really is not very helpful. Why is that? Just as I explained to you earlier, your hormone levels are fluctuating. They're up, they're down, they're right, they're left. So any hormone test that you're taking in your doctor's office is really just a snapshot in time. It's just where you were during those 5 minutes. It doesn't show what your hormones are going to be in the next hour, what they were the hour before, what they'll be next week. It's just a snapshot. And so it's not really useful information. Perimenopause and menopause is a diagnosis of symptoms. Remember, there are over 35 symptoms of perimenopause and family history. At what age did your mother start menopause? Your grandmother, your sisters? That's how menopause and perimenopause are diagnosed. And of course, menopause is officially diagnosed when you've gone 12 consecutive months without a menstrual cycle. So these are the things that I want you to be aware of when you are thinking about wellness, your wellness journey, because remember, the decisions you make about your health today are not so much about today, they are really about your future self, the person and the life you want to have 20 years from now. So why is that important during perimenopause? Because estrogen, remember, women's health is not bikini health. It's not just reproduction. Estrogen receptors are on every single organ in a woman's body. It's not just the heart, it's our liver, it's our kidneys, it's our bones. Think about that. During perimenopause, we start to have bone resorption and bone loss. Our risk of osteoporosis and osteopenia increases. It's a time when we should be getting information on doing weight bearing exercises, starting to add weights to what we're doing, including walking. Walking is against gravity. You could do that sometimes with a weighted vest or Pilates. I'm actually a Pilates instructor. And even though you utilizing equipment or mat Pilates as well, utilizing the body as resistance is very, very good. And remember, you're not doing it so much for today, you're doing it for the life you want 20 years from now. You have to be able to protect your bones because what? Falls, fractures end up being a risk for mortality later. What about urinary incontinence? The pelvic floor begins to drop and decrease as those estrogen levels drop. Things like Pilates and physical therapy can help you keep that pelvic floor lifted and decrease your risk of stress incontinence or urinary incontinence, which is the number one reason that women are admitted into the nursing home. The nursing home setting, the primary reason for women is incontinence. The majority of that is due to loss of estrogen, and everyone just sort of turned a blind eye to it. So make certain that you are aware of how to take care of yourself, what questions you should have, and how to arm yourself to live your best life, your healthiest life. Certainly here in Georgia, we want you to be empowered. We want you to be fulfilled. And women live on average about 6 years longer than men. But here's the caveat to that. We spend more time in our lives in poor health than men. We live 6 years longer, but we also spend a longer period of our time in poor health. That's also driven by the culture. Women are expected to suffer. We're expected to suck it up. We're expected to put others before ourselves. We are expected to minimize our symptoms. We're expected to accept others minimizing our symptoms, and we just shrug our shoulders and move on. But listen, perimenopause and pregnancy complications are not nothing. These herald an increased risk of heart disease for you. And even though you may be feeling fine, that's why it's silent. Do you know that estrogen receptors are also on the arteries of our body? That is why during perimenopause, you can have high blood pressure when you've never had high blood pressure before. That's because those arteries start to get stiffer. It's compliance that actually keeps your blood pressure down, meaning those arteries are able to expand and contract and expand. As your estrogen levels drop and those estrogen receptors don't get binding, then your arteries tend to stay more in that stiffer, that rod-like position, and your blood pressure goes up. Hypertension is a single driver of heart attacks and heart disease. And there's a reason it's called a silent killer, is because you probably feel fine. You don't notice it. There are no symptoms until you have an event, meaning a heart attack or a stroke or even death. So pay attention to your blood pressure. I am a great example. I had low blood pressure my entire life. Going through perimenopause, I also had low blood pressure, but towards the end, my blood pressure suddenly was high, and it was dismissed by physicians, not because I think they were trying to overlook me, but they had been taking care of me for so long. They knew my blood pressure was generally low to normal. And so for a couple of years, they just chalked it up to, oh, you must be stressed today, or you were rushing in. We'll just check it next time. We know your blood pressure is low, but it wasn't, and it had changed. And here's why it's important for you to have a home blood pressure monitor at your house. That's because you can check your blood pressure every single week, and then you can indicate to your physician when your numbers are changing, and it can be tracked along the way. It's part of what I do at Hello Heart. We have home blood pressure monitors for pregnancy, for menopause. We want you to be able to track that blood pressure, keep a log of it, and then you have a digital record that you can either send to your physician or talk to your physician about. Because the other thing that the health establishment is now increasingly recognizing is that blood pressures at home are likely better indicators of what your real blood pressure is than that single blood pressure in the doctor's office that could be related to any number of things. So these home blood pressure readings are incredibly important to your physician, and she or he may actually ask you for them and ask you to get a monitor such that we can see what's really going on. We call that in the real world. What's happening when you're out in the wild, so to speak. So when you are in your environment, as opposed to when you come into our very structured environment. We want to know what's really going on with you. And then it's important, if your blood pressure is starting to change, that you notify your physician immediately. What else can change that would be asymptomatic during perimenopause that also increases your risk of heart disease? Your cholesterol levels can start to increase. That's because estrogen and cholesterol share common pathways in the liver, and those cholesterol levels can increase, thereby further driving your risk of heart disease. In addition, because progesterone, which I haven't talked about, your progesterone levels are also decreasing, you can start to have poor sleep. It's either hard to fall asleep, or once you fall asleep, you have frequent awakenings, or once you get to sleep, you wake up early and then you can't get back to sleep. Sleep is also a risk factor for heart disease. In fact, we know if you cannot get 5 to 6 hours of duration of sleep and quality of sleep, your risk of heart disease increases. So definitely talk with your physician if you are now having difficulty sleeping, because sleep hygiene is another risk factor for heart disease. And then we talk about weight gain. Estrogen actually helps to keep weight off of the body. As we start to lose estrogen, not only do we start to gain weight, and we start to have difficulty keeping the weight off, we start to gain it in the visceral area, meaning in that midsection, fat around the middle, which is actually metabolically active fat, and it is more dangerous to have it around the middle because it indicates inside that you may be starting to have fat encasing your organs as well. So you want to think about the weight gain. Try to keep your weight down. Try to think about weight-bearing exercises like Pilates. I'm a big Pilates enthusiast. I'm a Pilates instructor. I have my own Pilates school. But there are any number of things that you can do and just add a little weight. The key is to move. Our bodies are made to move. And the American Heart Association, recommends 30 minutes per day, 5 days a week of high intensity or medium intensity exercise. Here's what I say to further simplify that. Pick something that you like to do, whatever it is. And maybe it doesn't involve someone else, such that you can always do it on your time. But pick something that you like to do and do it for 30 minutes a day. It has to be something that involves some motion, including walking up and down the stairs. If you're carrying laundry up and down the stairs, do it for 30 minutes. I want you to do something for 30 minutes a day where there's motion. And I want you to do it for at least 5 days a week. And at least for 3 of those days, add some weight bearing. And I use the laundry basket because that's a creative way of something that we're doing out in the real world that is weight bearing. A laundry basket full of towels. Now you've got weight bearing as you walk up those stairs and come back down those stairs. So it doesn't have to be weights in the gym. Think about things that you are lifting and carrying around your house. In Pilates, oftentimes I will integrate bands and a magic circle. But we also, as you know, in Pilates can use our body, and there's also any number of equipment. So I want you to move because exercise is incredibly important, and it certainly is incredibly important as we move and transition through perimenopause and menopause and begin to gain visceral fat around the middle, start to get heavier weight, and obesity is what? Another risk factor for heart disease. So it's amazing that we haven't thought about this before with menopause because all of these things are independent risk factors for heart disease, obesity, visceral fat, hypertension, cholesterol, sleeplessness. And then during perimenopause, they're all happening at the same time. So, of course, our risk of heart disease is increasing. And then I will end by asking everybody, especially women, make sure you always check your vitamin D levels, vitamin D. And if they are low, please do what you need to do to keep your vitamin D levels up in the normal range as well. That also helps you to live your healthiest life right here in Georgia. Thanks for tuning in, and I hope that was helpful. I'm Dr. Jayne Morgan. I am a cardiologist here in Georgia, and I'm the Vice President of Medical Affairs for Hello Heart. You can follow me on Instagram at Dr. Jayne Morgan, DrJayne Morgan. But on any of the channels, including LinkedIn, you can follow me right there at Jayne Morgan, MD. Thank you.